Well, first of all, thank you to the organisers for inviting me to speak. So I'm going to talk about two main topics. I'm going to start with child neurodevelopmental disorders, which is the area that I work on, and I'm going to focus particularly about when children grow up, and I'm going to provide the example of ADHD. I'm then going to argue how findings from cohort studies have shown us that a developmental perspective is not just relevant to us in child and adolescent psychiatry, but is actually relevant across the lifespan. And I'm going to give some examples on schizophrenia and depression. I mean, clearly there's a huge amount of research on cohorts across the world. I can't possibly describe the details or the detailed findings, but what I'm going to do is take a few selected findings to illustrate some key sort of high-level conceptual points, which I hope gives you a flavour of the sort of work that's going on. So, I'm a psychiatrist, and we've heard quite a lot about overlaps between different disorders, not just in symptoms, but also in terms of risk factors. But one crucial thing that they do vary on is their age of onset. So we have the child neurodevelopmental disorders like autism, ADHD, language problems that start early in development. Then from sort of primary school, middle childhood onwards, we get the emergence of anxiety. And then, as we've already heard earlier this morning, after puberty, so much more typical in late adolescence and adult life, we have the emergence of schizophrenia and mood disorders. So we have got these variations in ages of onset. So let me start now with child neurodevelopmental disorders. This is the DSM-5 grouping of child neurodevelopmental disorders. It's going to be pretty similar in ICD-11. So we've got ADHD, autism spectrum disorders, a number of other disorders that are really defined by their onset in terms of manifestation being in the early developmental period. Not all of them, but most of them also, rather than having a remitting, relapsing course, tend to have a sort of more typically a steady course. And also males are more affected. So the one striking feature about child neurodevelopmental disorders is that there's very strong overlap. And as clinicians, we tend to talk about yes-no diagnosis. Have you got, as a child, got autism or not autism? But cohort studies have shown that these yes-no categories also behave as continuous traits. So these overlaps are important. So, for example, if we take the example of the overlap of ADHD and autism, people who have these overlaps, they show much greater impairment. And these are the sorts of individuals that are likely to be picked up and referred to clinics. And population-based cohorts are particularly helpful because they enable us to look at those cohorts. Now, quite a lot of work I've done is based on patient studies. And patients, of course, select and perhaps even exclude people with those overlaps. So, one of the first questions I get asked in clinic is, what's going to happen to my child when they grow up? So what happens to children with neurodevelopmental disorders? Well, for many neurodevelopmental disorders, there's improvements with age and with maturation. So, for example, language or motor difficulties, as individuals mature, there are some improvement. And actually, longitudinal cohort and clinical studies have actually put to rest this belief that children grow out of these disorders. They've shown that they do not, and that actually many remain affected in adult life. However, I don't think it needs a clinician to tell you that the symptom profile and the type of impairment of, say, someone with ADHD at the age of 30 or 40 is not going to be the same as somebody at age 5 or 6. And this is a real issue because we don't actually really know how to adjust our symptom profiles for the purpose of clinical practice for developmental changes across the lifespan. And I think we heard in some of the working groups yesterday that one of the advantages of cohort studies is that you can actually look at the natural history and also examine typical development. So I'm going to focus on the example of ADHD, which is a disorder I mostly work on. So, as I said a lot of individuals with ADHD do show some improvements with age, but we now know that by adult life, around 2/3 show either full-blown ADHD or ADHD symptoms with some impairment. So it's not just a childhood problem. However, there's huge variability in longer-term outcomes. So what influences those trajectories? Well, we know from older studies that if you've got a stronger family history of ADHD, and twin studies have shown where there's higher heritability, that tends to influence later trajectories. So just to give you an example of a cohort finding, these are findings from the UK birth cohort that Peter earlier mentioned, which is the Alsbach birth cohort, which started in pregnancy. And these are looking at ADHD scores from ages 4 to 7 using repeat measures and looking at trajectories. And I won't go into the stats, but you can see because it's a population, not patient cohort, most people score very low. There is a group that score persistently high, and these are the sorts of individuals that one might see in clinics. There's a group with an intermediate level of symptoms, but this is a particularly interesting group because they start off with high levels of ADHD symptoms, but then they remit by adolescence. So, what we did is take some of the genetic findings, which are coming from patient studies, and looking at common variants taken from genome-wide association studies to generate a composite of ADHD genetic risk scores in the population cohort using those patient data. And what we predicted is that those ADHD genetic risk scores may be associated with future trajectories, and indeed that was the case. People with a more persistent ADHD trajectory showed higher ADHD genetic risk scores. We've heard a lot about genetic overlap, and that is a very consistent finding. But what I want to highlight here is that actually we had specificity. There was no association with the trajectories in terms of association with schizophrenia genetic risk scores, which have got much greater power than ADHD genetic risk scores because of the sample sizes of patient studies, or bipolar or depression. It was just the ADHD genetic risk scores. The other thing we looked at is that we hypothesized that children who had more than one child neurodevelopmental problem, not just ADHD, they had a language problem or an autistic problem, we found that the ADHD genetic risk scores were associated with those overlaps, multiple difficulties, which are called multimorbidity. And actually, multimorbidity, that clinical multimorbidity in childhood, independent of the genetic risk scores, predicted that ADHD persistent trajectory. So it looked like from this cohort findings that the continuity into adult life, not everyone does show continuity, but genetic loading and the sort of neurodevelopmental, having more than one neurodevelopmental problem seem to contribute. So I'm going to move from child neurodevelopmental disorders to disorders that typically onset after childhood. And I'm going to give the example of schizophrenia, which is not a disorder I work on, but I think the findings from cohorts are interesting here. So we know from studies of affected adults that many report childhood difficulties from very early on, even though the psychotic episodes and the sort of the defined features of schizophrenia start after mid-adolescence onwards. So are these early childhood difficulties an early manifestation of that underlying genetic liability? We would think so. We've heard quite a lot about that from people like Dan, that actually schizophrenia-associated genes have been implicated in early development. So how early do they manifest in the sorts of phenotypes we might look at clinically? Well, this is again taking schizophrenia genetic risk scores from patient genetic discovery studies. These are the common variants, and computing genetic risk scores in the Alsbach cohort. And what we found is that the schizophrenia genetic risk scores were associated at age 7 with poorer cognition, more difficulties with social communication, more difficulties with language, and behavioural difficulties. And different measures, but actually if you go back as far as age 4, these children with higher genetic loading show more behavioural difficulties and also differences in terms of social development. So in terms of schizophrenia, being an adult disorder, here we have that the schizophrenia genetic liability actually is manifesting in the general population as neurodevelopmental problems from very early in life, suggesting that some of the high-risk studies that have reported some of these sorts of impairments in early childhood are likely the early manifestations of that underlying genetic liability. So I'm now going to talk about depression, different disorder. And depression can present in adolescence. You can also, of course, have depression in midlife. And does it matter that we're calling it the same thing? Depression at one age versus depression at another age. And for many studies where we need really large sample sizes, all these samples, regardless of age, are grouped. Well, we know from longitudinal studies that somebody who's had an episode of depression during adolescence, around 70% will have a recurrence in adult life. There's continuity between child and adult life. The other thing we know is that the offspring, children of parents with depression, are themselves at elevated risk of depression. So these studies suggest it is actually the same underlying liability for depression regardless of age. However, there are some puzzling findings. So, for example, developmental studies show that the gender ratio differs across the lifespan. So in children, depression, although rare, the males and female ratio is equal, whereas it's only after middle adolescence onwards you get the typically observed female excess of people with depression. So it does not look identical in this respect. Also, treatment response is not identical for children, adolescents, and adulthood. And also, early family and twin studies suggested that depression at different ages showed a different genetic architecture in terms of family loading and heritability. So just to give you another illustration, from a genetic perspective, this was a large genome-wide association study looking at common variants for major depression, and the original authors found that an earlier age of onset for depression, and early here is actually less than 27 years, the depression showed a stronger association with schizophrenia genetic risk scores, whereas the older depression, greater than 27, was more strongly associated with depression risk scores. The genome-wide association study of depression is very much larger now, and my colleague Catherine Lewis and Saskia Hagnas in the Institute of Psychiatry very kindly replicated these findings and found exactly the same in the largest study. So what about cohorts? So by way of example, I'm going to talk about another UK cohort, the 1958 cohort, or the NCDS. And here we're looking at emotional problems. Because it's such a long study, the measures aren't, clearly not great at some of the ages, but basically looking at emotional problems, anxiety, depression from 7 to midlife. And what we found is from childhood to midlife, schizophrenia genetic risk scores were consistently associated with depression, whereas the depression genetic risk score association was more consistent later in adult life. This finding comes out much more clearly in the Alsbach cohort, who of course are younger, and we looked at depression. This is work conducted by Frances Rice in our group, and she found again that the earlier depression actually looked more neurodevelopmental, stronger association not just with schizophrenia genetic risk scores, but also ADHD genetic risk scores, and a later, more stronger association with depression risk scores. So, to conclude, I hope I've given a taste that, coming from a cohort and patient perspective, that actually a developmental perspective is really crucial for research. And actually longitudinal population cohorts are really invaluable for investigating development, not just etiology, which are focused on, but also sort of natural history, amongst other factors. The really big advantage is we can capture individuals before they get disorder onset. The sorts of patient studies I've been involved in, they're great, but they've already got the disorder. The other thing is, for many cohorts, we have repeated measures which allows us to look at trajectory. It's easier to look across disorder, and it avoids the clinic referral bias. But how do we make that huge bridge from neuroscience? Many of you here are neuroscience colleagues. How do we make that bridge from cohorts to neuroscience? We have to have some sort of cross-connection. Well, I've given you an illustration of how genetics is one way that we can talk together. Imaging is, I think, another way, perhaps cognitive tasks, and perhaps in the future biomarkers, because some of these cohorts, of course, much more challenging when we're talking about psychiatry in the brain. The challenges of cohorts is people drop out, and the most interesting people, the ones with higher rates of psychiatric disorder, they're the ones that drop out. They're also not so great for looking at rare exposures, for example, rare genetic mutations, or less common exposures like very preterm birth. We've also got the problem that measurements change over time. I showed that with the 58 cohort. They change from child to adult, and you have an underrepresentation of the most severely unwell patients, the really severe ADHD, autism, schizophrenia, because the prevalence is low. They're great for looking at environment, and Peter touched on this, and across the lifespan, but they're observational, so on their own you can't tell, because of the problem of confounding, whether these environmental associations are causal just using cohort designs. So you do need other designs, so what about the future? Well, we need other sorts of designs to look at causality of environmental exposures. We can't always do randomized control trials, but there are some sorts of cohorts that can give us some information about causality. Twin cohorts is one, taking advantage of policy changes where a cohort is exposed to them, and embed designs within cohorts to look at this. The most severely affected, well, the other way of doing that is having enriched cohorts, those who are going to be particularly enriched for having disorder. So high-risk samples, for example, the offspring or siblings of people with a disorder, or those carrying rare, highly penetrant mutations, and you can follow up through childhood, or those who've been exposed to very early environmental adversity, for example, preterm birth, who will then be enriched. But again, we would want harmonisation with the cohorts. So for the future, we do need to think about how we're going to get an increased depth of measures in our cohorts, harmonise the measures across ages, and also across research designs if we're going to try and build bridges. And I'd just like to end there with acknowledgements. And particularly a lot of this work that I've just presented now has been work conducted by postdoc Lucy Riglin. Thank you.